Three, two, one.
Here we go!
Welcome to the No Normal Show, brought to you by BPD, a marketing services firm that delivers the future to healthcare's leading brands. This show is where we leave all things status quo, traditional, old school, and boring in the dust, and instead we celebrate the new, the powerful, the innovative, the bold, all focused around the future of healthcare marketing and communications. I'm Stephanie Wierwille, EVP of Strategy and Innovation here at BPD, and I am joined by a very exciting returning guest, Kate Caverno, SVP of Payor-Provider, Practice Lead. Hi, Kate.
Hi, Stephanie. How are you?
I'm so good, and I'm so happy that you're joining. I'm so excited for this conversation.
Me too. Thanks for having me back. I appreciate it.
Yes, we're going to get into all things finance, payer-provider relations, managed care, contracting, negotiations today. It's going to be a really fun one.
I'm excited.
So, with that, why don't I run through our agenda real quick so people know what's coming. First, we've got a couple interesting headlines. Becker's Hospital Review published a list of 82 health systems with strong finances. And so, out of sheer curiosity, we kind of geeked out a little bit and said, what are the patterns happening on that list? And, what can all health systems be thinking about in terms of financial strength? And then secondly, there was a headline around why Medicare Advantage contract negotiations are getting heated. So Kate, that one's all you, and I can't wait to hear about what's hot, what's fiery. Okay. And then our main topic, surprise, surprise, is all about payer-provider relations and managed care. So as we look to 2026, we want to make sure that folks are really thinking ahead to everything from what's going on with reimbursement rates to negotiations to contracting and beyond. And also just what's on the mind of payers, What are they thinking about? So here's a few just little housekeeping items. We always like to let folks know what's going on. And I think something really exciting is happening next week, actually. We've mentioned it before, but it is, happening right away. Actually, by the time this will be live, it will be kind of in progress. So BPD is partnering with eHealthcare Strategy and Trends for AI and Healthcare Marketing Week. And that really is a full week of virtual programming, a virtual conference for marketing leaders, digital leaders at hospitals, health systems, and other provider organizations. So we'll have speakers from a wide variety of health systems talking about what they are doing in the AI realm. Everybody from UChicago Medicine to UNC Health, Baptist Health South Florida, Mount Sinai, Advent Health, Providence, Cleveland Clinic, Northwell Health. Really a star-studded lineup that I'm really pumped about. So if you're not signed up, and if you want to jump in even midstream, there's a whole week. So that will be Monday through Friday, starting on December 8th. So by the time this launches, we'll be in the midst. But you can sign up at ehealthcarestrategy.com/AI and Healthcare Marketing Week, and we will drop a link in the show notes so you don't have to just type it all in. Another event that's super exciting is, of course, the Joe Public Retreat. And I think we've talked a lot about that, so I won't go into detail, but it's a whole event focused on AI, and you can sign up by visiting bpdhealthcare.com. And then a couple specific notes really focused on our topic of today. So we've got a recent blog that just came live called Bridging the Gap, Marketing and Managed Care Working as One, authored by Kate, who is here. So I know we'll get into some of those details later on about, how managed care trends can really apply to marketing and vice versa. And then lastly, we have a report from a few months ago, but still very relevant, called Good People, Flawed System. And we'll be talking more about that today. But that is all around what is in the minds of payers. Anything you want to add, Kate, especially on those last two before we jump in?
I think the blog post that we just wrote a few weeks ago, 2 weeks ago, I think at this point, but it's one of those things that maybe doesn't seem quite so intuitive, that managed care and marketing belong together. But you ever have those late night metaphors pop into your head? They're like the Clark Kent and Superman, right? They're two sides of the same human, and they're both out there championing, their cause, and they're working together. So, it's there are closer ties than you might initially think.
Yeah. I thought this blog was just so interesting, and we'll talk more about it. But when I think about marketing's job is all about, of course, making sure that revenue is strong, making sure that we have margin so we can, do our mission, and also often getting tasked with things like shifting payer mix. And on the managed care side, same thing, right? Making sure our margin is strong, making sure that we have relationships with the payers that allow us to have the right payer mix. So to your point, Kate, it's the same objectives, but done in very different ways.
Yeah, marketing gets all the attention and the glory like Superman, and Clark Kent is still there, right? Managed care behind the scenes, getting those strong contracts and making it happen. So both really critical to a successful organization.
Yeah, awesome. Okay, so your Superman analogy actually maybe is a good little segue here. Kate, I know you've been on the show before. We love to talk about pop culture. We love to kind of share before we get into the geeky finance and payer provider details. We love to just kind of see what are you doing outside of work? What are you leaning into? I think you had shared that there's some really interesting shows and movies that you're watching. So what have you been watching recently?
Was elbow deep in The Beast in Me on Netflix. I don't think I've ever binged anything faster. It was so good. It's Claire Danes and Matthew Rhys and Jonathan Banks and I'm sure Brittany Snow, how could I forget? So cool cast, and it's just gripping from start to finish. I think there's only 8 episodes, so it's not crazy, but really, really fascinating. Have you seen it?
No, I have not, and I'm adding it to my holiday binge watch list, because it sounds really interesting.
A must.
Yeah. I think you and I both watched Wicked for Good, right?
We sure did. And I think we have slightly different opinions.
Uh-huh. Let's debate.
Okay, you first.
I loved it. I'm a big Wicked fan. I think you and I both are big Wicked fans,
Yeah.
so that is where we agree.
Yeah.
But I thought Wicked for Good was just lovely. I really loved the cinematography of it, the storyline, of course, the acting. I've been especially nerding out afterwards on how it was shot. So I think that's what's getting really, really interesting is seeing all the background commentary. They've done a great job from a marketing perspective of sharing, like, here's the costume designer and here's their thoughts, here's the hair and makeup, here's cinematography, like breaking down the scenes in a really interesting way and kind of going back to movie 1 as well and doing that there. So I think it's just sucked me in. What was your take?
I also loved the cinematography. I thought it was beautiful. The costumes were gorgeous. Of course, Cynthia and Ariana can sing the phone book, and I'd listen, and they're just amazing. And honestly, I thought the acting was great too. I don't know. I've seen the musical, the stage production. I've seen it on Broadway. I've seen it in London. I've seen it more times than anyone should see a single production. But I love it. But I'm not saying that makes me an authority. But I do feel like I have the context. In the stage production, Glinda and Elphaba, they're tight. They're together no matter what. Um, and I felt like in the movie, I just didn't have that same bond between them. And they got to like the song For Good, and I was like, well, these people don't even like each other. Why, it's supposed to rip your heart out and be gut-wrenching that they're never gonna, spoiler alert, see each other again, right? And it left me lacking a little bit.
Yeah, I can see that. I can understand that. I think, as always, the movie and the Broadway show or the stage production or even book, right? It started with a book, um, very long time ago, and every one of them is different, and so there's always that little tiny bit of letdown when you know the background and the details.
Yeah.
But
Still great. I'd watch it again, but as the diehard, and you too, like I wanted it to be perfect.
yeah.
Yeah.
I enjoyed all the additions and the little Easter eggs and the Wizard of Oz Easter eggs especially, so that was
That
fun.
was fun. Yeah.
Okay, so let's get into it.
Okay.
This is fun for me. It's our first headline, I think, is fun, maybe not Wicked for Good level, but Becker's Hospital Review shared a list of 82 health systems, and they were the I don't know if they were necessarily the top, but in terms of those that have strong operational metrics, strong financial performance, strong positions, strong margins. And so we did a little dive into what are the themes, what are the patterns. I think the point of this, I'll just say it up front, caveat, the point is not to be like, oh, this is a playbook for health systems to go. No, like obviously a lot of these things have you can't necessarily control some of them, right? Some of them are based on the market, some of them are based on historical, all kinds of different things. But just for sheer interest, I'll run through these themes, not all of them, but some of them. And then, Kate, I want to hear your take. Um, so I think the first one is one that is not really controllable, and that is the market. What market are you in, and what is the demographics of the market, and what is the payer mix of the market? Very relevant to today's conversation. Um, so some of those things, might just be dependent on geography or region or demographics, but really, really play into how strong margins can be and commercial payer mix specifically. And along with that, what is the market dominance and scale? So I think, of course, marketers are always working towards this one, making sure that the health system is the market leader, but that takes time, and scale plays into operations as well and into the whole strategy behind things. Service line mix, revenue diversification are the next two. I love the revenue diversification theme because I think that's so fascinating. It doesn't just mean what service lines are you focused on. It means also what are the other things that maybe play into how you generate revenue. M&A, which I know is also your world, Kate. And then big theme right now is innovation, but also workforce efficiency, workforce being the highest line item in terms of expenses. And so how is the system set up operationally to be able to make sure that that they have a scalable workforce and that they have the right mix of employed versus, locums versus, other types of, workforce. So let me stop there. What's your take here?
Well, it's an impressive list, right? 82 systems that they consider strong. I think strong with an asterisk, right? What does strong equal? And strong for not-for-profit systems versus strong in the context of any other industry, right? Like a health system is considered strong when the operating margins are in the neighborhood of 3 to 5%, maybe 8%. Meanwhile, you've got Amazon at 10% this year and Apple's at 26%, right? So it's all in context. And even if you look at your own personal finances, right? Like your financial advisor would tell you to save 10 to 15% of your income, right? So that's what you need to have cushion and save for a rainy day and all of that. But the average health system is at 1 to 2% and strong is at 8%. So it's all relative. But I mean, the commonalities you pointed out, whether it's, they're looking for stability, right? That's the underlying, whether it's M&A or the workforce efficiency or their service line mix, it's all in this search for how do we anticipate the future, create stability for our people and for the communities that we serve, and not overextend ourselves because we really can't afford that. How do we maintain, being a top place to work and all of those things? It's just really complex and complicated. So for these systems who are managing to be at, somewhere in the 5 to 8% range, good for them. I mean, it's a tough world out there.
Yeah, it is. It is a tough world. And I think that's probably why Becker's published this list at the moment they published, is because there is all that conversation in terms of, to your point, the margins that are even strong are not that strong. And so many systems are operating in the red, especially the smaller rural systems or even hospitals. And the ones that are strong, 3 to 5%, that's enough to grow. That's enough to scale. That's enough to, continue expanding. But it's not enough to do every single thing I just listed out. It's not enough to invest in innovation. It's not enough to maybe hire the talent you fully need, especially when that talent doesn't even exist, because then what you have to do is go create new talent, and that's expensive. So the lack of capital is a struggle no matter where you fall on this list of strength. And I think marketers, communicators, and payer provider, type of folks all play a role in the strength.
Yeah, absolutely. Going back to that blog, right? Of the mixture of managed care plus marketing. How do you talk about the financial stability and headwinds that you're facing while also providing high quality care and attracting top talent and expanding your reach and supporting rural systems and all of the things that people expect from a strong health system, but also not position yourself, for your next negotiation to have the payer say, well, clearly you don't need our help, right?
Yes, that. Well, yeah, let's dig into that maybe a little bit later because I think that's super important point, which is even if, let's say, you're at the top of this list, like, that's not really a good thing sometimes
Right.
in some
Yeah.
contexts, It's not a good thing sometimes in terms of being seen as a nonprofit. It's not a good thing sometimes in terms of how you market and how much you spend on marketing and how you're negotiating with payers. And so it's just like, it's such a tough world because we're not Oreo, we're not Nike, and we can't, just spend.
Well, and your
Uh,
not-for-profit status is being called into question every other day,
yes.
right? Whether it's by the local, state government or federally. I mean, it's yeah, you need enough to survive, but not too much that you get scrutinized
Mm-mm.
for it.
Goldilocks.
Yeah.
Yeah. Okay, next headline. I'll let you unpack this one. So the headline is from Healthcare Dive, and it was an article that just came out around why Medicare Advantage contract negotiations are getting heated. So, Kate, for those in the room maybe who are not living in your world every day, first of all, if you can give us just the teeniest overview, Medicare Advantage, what's important about that, why does it matter, and then what's getting heated?
Yeah. So Medicare Advantage is technically a commercial plan, but it's a secondary option to traditional Medicare. So which is government backed, right? So the government has set a rate for what they'll reimburse for people who to take up Medicare plans. There's also a supplement plan that you can get that will cover your pharmacy and things like that. Um, but payers have done a really good job of marketing this plan that is it's got the word advantage in it. It must be great, right? But typically what it means is that you have a more narrow network. You don't have access to all the same providers as you would if you had traditional Medicare. You might not have a premium or a copay, which is great, but because your access is limited, you also are probably required to have a primary care physician. You also may be subject to prior authorizations, and that those may be denied. So it's just a little less hassle up front. Seems great. Also comes with a silver sneakers program, right? You can get a pedometer, um, but in the long term, might not actually be as great a plan for you as a patient. Um, and then on top of that, from a provider lens or as a negotiator, right? Payers have said, well, the government will pay you, let's say, 80 cents on the dollar for what it actually costs to provide care. We're going to bring what we're actually going to offer you less than that. In many cases, what we're seeing as we're negotiating or helping our clients negotiate, they're being offered less than the rate at Medicare of traditional Medicare, because of the volume that they're promised to bring. And it's a double-edged sword because they've created all of the volume. They've created a lot of people who want a Medicare Advantage plan. So we, as a system, don't want to say no to them. We don't want to be out of network with a Medicare Advantage plan because that's a lot of people that we can't take care of. And that number of people is growing. 10,000 Americans every single day are becoming Medicare eligible, and they will continue until 2030. So we've talked about the Medicare gap for 10 years more. And it's only going to get wider as a result of volume alone, patient volume, but add to that policy changes that are coming from the government via the one big beautiful bill, we anticipate there will be cuts to Medicare, Medicaid funding, which means that the cost of providing care for these patients is going up, and the rate of reimbursement is going down. So what we end up is with this sort of stalemate where both payers and providers are sort of looking at each other like, we don't really care if we're in network on this. We're losing money and we have all these patients and they're buying it, but we pay a lot of money for care for older patients. So yeah, take it, leave it. We don't really care. And all these patients are being caught in the middle. It's really tough.
Yeah, and this is really, I mean, this is at the heart of our main topic today too. So this is like negotiations are heating up across the board. And I think what you just said really sums up probably what we're seeing walking into 2026, which is the cost of care is rising and the negotiations are getting tougher and tougher. And, there are, reimbursement rates that are not what they should be, right? And so maybe just kind of take me through as we walk into 2026. How are you seeing this play out at a macro level? So beyond Medicare Advantage, even what's happening in the realm of either negotiations or reimbursement rates that kind of tie into this larger theme of like this mismatch of the cost of care versus how much is being paid.
Yeah. So, I mean, Medicare Advantage is going to continue to be a point of friction for a lot of systems and for payers, particularly those in more rural areas where the population is skews more toward the Medicare age range, and where there aren't other providers in the region to take care of those patients. You won't have that option. But we are also going to see, we saw this with Humana, for-profit payers are able to just exit that market. Unlike a health system where you're planted where you are, this is the geography you are playing with or caring for, the payer can just say, I think we'll go. This market's not for us. We'll go somewhere else. So we're seeing that on the MA side, but then with commercial plans, we don't like to use the word subsidize, right? We don't like to talk about how commercial insurance subsidizes government payers and Medicare Advantage included, but that's what's happening. And so as the gap it widens on the MA side or the Medicare side, the importance of commercial contracts skyrockets, right? We have to have those strong contracts. And payers push that on to employers. Employers look at the rising costs for their premiums of deductibles, and they're just trying to provide, good benefits for their employees. And that's becoming harder and harder. And most health systems don't really have a strong employer relationship path. So the conversation around these commercial negotiations is we need better rates. Meanwhile, we're building the fancy new tower and we've acquired the new system and all of those things that we're doing to ensure our financial future and our stability come back around, as we sort of talked about at the top, to hurt us at a negotiation. So it's that trend I think will continue, and man, health systems have an uphill climb to articulate their value and the headwinds that they're facing.
Yeah, I mean, as you're unpacking this, I think like, gosh, how many times if we all had a dollar for how many times people said healthcare is complex. But like what you're unpacking is why that statement has become meaningless is because it's so complex, it's just ridiculous. And so, you have I love how you're saying like it's almost like a domino effect, if you will. Like health systems need strong margins in order to survive, literally serve their patients.
Yes.
And again, strong does not mean strong in other industries. You already covered that, right? So therefore, they need relationships with payers. Payers, got to be payers. We have a whole piece we talked about earlier, good people flood system.
They have shareholders to
They're-
pay.
They're right. They're doing what they're doing to stay in the system. We could talk all about that on a separate conversation. But so therefore, you mentioned they sort of push it off to employers and have to make their own business decisions. And now employers, they're like, It's almost like everyone who can is wanting to get out of the game where the game does not serve them. Health systems are the only ones who cannot get out of the game because if they do, and we see this all the time, when they close, then people are left with zero care, and now you have a collapsed system. So I didn't mean to go down the full complexity rabbit trail, but I think the challenge is, you know, everyone is squeezed by the system having to do what they have to do. So maybe with that said, Kate, what do you think can be done in 2026? What should health systems be thinking about, either in terms of how to unpack these trends further, or what do they need to do?
It's complicated, Stephanie. No, it's one of
It's complex,
it's
right?
complex. The marrying between the managed care and the marketing, I keep saying it, but it's really critical. And I saw a LinkedIn post today. I won't name the system, but they did a really interesting thing that I haven't seen a health system do, which was to talk about their cash on hand and why they're a not-for-profit system and they need reserves, and those reserves help them to pay their employees when COVID comes, right? And their revenue stream which is based on sick care primarily, is completely disrupted. And they need to, you mentioned sort of those other revenue streams. I think there are health systems out there that have AI and innovation labs where they're backing things that are not even healthcare related, but because we know so many innovations have sprung up and then they, without meaning to, have healthcare implications. So backing those things is actually not only a pathway to profit, but also could change the game in healthcare. Um, so I think just having conversations about these headwinds in new and they're not even that bold, but real transparent ways, whether that's posts like LinkedIn, like I saw today, or having conversations with your chambers of commerce and getting in front of employers to say, hey, we know your payer is telling you that they're saving you X dollars a year by enrolling your employees in whatever plan. But here are the ways that we as the health system are saving you money and by, being a low cost provider, by making certain measures that make our care more affordable. um are there just conversations that we're not taking the time to have right now?
Yeah, this brings us to, I think, a really interesting discussion, maybe even debate, which is how much should health systems take on the responsibility to have those conversations? And the way you outlined them, those conversations can be everything from, kind of sharing what does it take to make healthcare possible in this country. It can be lawmaker discussions, it can be community leaders, it can be consumer
Oh,
discussions.
yeah.
I don't know. I would love your take, Kate. What do you think? Do you think it's possible? And if so, what are the starting steps?
The optimist in me says it has to be possible. um and no one is coming to save us. The advocacy groups who are out there are trying. The hospital associations are trying, but there's no one size fits all. And so you end up with sort of a vague attempt at explaining the complexities that are not specific to your system and what your patients need from you. So, but there's historically been sort of the reticence maybe to talk about these headwinds and the challenges because we're not for profit, we're not supposed to talk about finances, and it feels like we're beating our chest when we do, or like we're crying poor. When you're either in the camp of the 82 on the list who are strong performers, and talking, as you said, talking about that can be challenging and somewhat dangerous. Um, and the folks on the lower end feel like they're crying poor, but they're I mean, the truth is that most systems are less than a year away from closing if things stayed the same, right? Like,
Yeah.
there's real financial risk to not having these conversations. and nobody is coming to save us.
Absolutely. Yes. Nobody is coming to save us. That
Sad.
that's something to sit with. That's something to sit with, and really sit in for a second. When I think about just the state that we're in, I mean, healthcare is all over the news. It's all over, it's been a huge policy topic. It is on top of minds for consumers. And I actually have some fresh off the press data, some studies we've been running at BPD. And one of the recent ones, I think we talked a few episodes ago about how consumers really feel about healthcare marketing. And we talked about that. And what was interesting there was when people were asked what kind of marketing messages are you not receiving from health systems, but you would like to, the number one answer shocked me, and it was information about laws that impact healthcare. And the number 4 answer was information about navigating health insurance. So that coupled with some other data that we got where consumers seem to really understand to some degree the challenges in healthcare. There was another survey we ran that showed us that consumers, they understand health. They don't understand health system finances, but they understand like staffing shortages. They understand some of this insurance complexity. So I wonder, have we treated consumers like they're dumb for too long? Like, have we just thought, oh, this is too much to break down. This is too complicated. And I'm not saying we need to unpack everything, but I know your team has done a lot of work of helping consumers be on the side of health systems, and you all have been incredibly successful in that. Um, is there any learnings you have from that work that you think could apply in 2026 broadly?
Yeah, I mean, I think we have sold consumers short to some degree. I think, I was having a conversation the other day with a friend who is not in the healthcare industry, and he said something like, "Are there changes happening in healthcare that I mean, my copay went up dramatically, and what I'm paying for healthcare today is crazy." And with all sincerity, and was really looking for what's happening, and live, eat, sleep, breathe this all day, and I was like, what do you mean you don't know what's happening? But he was truly hungry for that information and to better understand it. um and I think it's something that we all experience. You go to the doctor, whether it's for you or your parents or your kids, or, we have these encounters and we feel helpless during them because we don't understand the system. So I, yeah, I think people have the capacity to understand this. If I can understand it, somebody else can understand it, right? Um, and I do think that it is part of the health system's job, not their whole job, but we have to show up to educate our patients and consumers in a way that is, approachable but factual, and doesn't hide behind we're okay and everything's sunny and rosy and we do amazing things for our community. Yes, we do. And we do that despite delayed payments from payers and despite policy changes that are trying to cripple us at every turn. And there are real reasons for hospitals closing or services shutting down, or the long waits in your ER. there's
Yeah.
there's
Yeah.
reality behind that.
Yeah. Whew. Wow. This is a great conversation. I think in the last minute or two, Kate, if we think about 2026, all these themes together that we've talked about, if I am a health system and I have $1 to spend, where do I spend it?
I would go
Where
talk
do I
to
spend my 1 hour?
Yeah, I would go talk to your employers. They hear from payers at least once a year, twice a year, as they're picking out their plan and learning about how the plan is saving them and their employees all kinds of money. But they very rarely hear from health systems. And the truth is, if you're sitting in a negotiation and you have a handful of big, moderate size employers who can step in and be on your side and talk to the payer about why it's important for your health system to stay in network, that is going to be the biggest mover you have. Beyond patients, I hate to say it this way, but their voice is too small. It's one at a time versus an employer that represents 100, 1,000, 10,000. The bang for your buck is going to go a lot further talking to and gaining employer trust than focusing on the patient community.
Yeah, that's great. I think that's really important as people finalize, hopefully they're finalizing 2026 planning and thinking about audience prioritization. And there's so many audiences to talk to. But I rarely see employer audiences top of the list, especially on the marketing and communication side. I see, employees, I see, policymakers, but not employers. So thank you for raising that.
Pleasure. Thanks for giving me
Thank
the
you for
opportunity.
joining. Yeah, this was a great conversation. I feel like we could go on all day, Kate.
I definitely
Probably have, we should probably have follow-ups. We should probably double click into some of these things and maybe monitor how things go over next year.
Let's do it.
All right. So thank you everybody for listening. Let us know your thoughts if you've got them. Share the show with friends and colleagues. Give us a review, a rating. We love all of that. Don't be satisfied with the normal, of course. Always push the no normal. Always push into the complexities that Kate just unpacked. And we'll talk to you soon.
3, 2, 1.